When they come to our clinic, we offer, we're one of the few clinics in Sydney that can offer everything. So we have, Presbeyond, which is our laser option. We have Smile Pro, LASIK and PRK. We have ICL surgery. We have clear lens extraction or refractive lens exchange, and then we have cataract surgery. So we've literally got all the options. So when you come to our clinic, you can be rest assured that we're picking the best option for your eyes. We're not just picking an option that suits us. We have the whole array, like the whole range, and we'll pick the one that's best for you for many reasons. Occupation related, it's anatomy related, it's lifestyle related, it's based on your visual requirements. So we really think deeply about this. That's why our assessments are so long. They take up to an hour and a half, and patients sometimes say, why is it so long? And that's why, because we're deeply thinking about what's going to give you the best option.
If you wear glasses or contact lenses, you know the small but constant compromises. Fogged up lenses in the rain, forgetting your spares on a trip, dry eyes from long contact lens wear. It's part of daily life. Or perhaps the years are catching up and cloudy vision is beginning to impact your quality of life. What if you could restore clear, sharp vision and reduce your dependence on glasses or contact lenses altogether? That's what we're exploring today. I'm joined by Dr. Erica Darian-Smith, Sydney ophthalmologist and co-founder of Eagle Eye Surgeons, where she helps people regain clear vision and confidence through ocular eye lens surgery. She's also been nominated and a finalist in the Australian Professional Small Business Awards. Today we're going to break down what eye lens surgery involves, who it's for, and what you can expect, so you feel informed and empowered to take the next step. But first of all, who am I? My name's Paul Salloway. I'm the owner of Optics Digital. We're an agency that helps eye care professionals to grow their practice. So hello, Erica. Good to see you again.
Hi, Paul. How you going?
Very good. Thanks. Very good. In a recent interview I had with your co-founder, Dr. Mitch Lee, we talked about the retina, which is like the back of the eye. If you want to use the old school camera analogy, that's where the film is. But the front of the eye, I think that's your sort of like zone of expertise, isn't it? The cornea and the lens.
That's right. Yeah.
Right. So maybe that's what we're going to talk about today. So I think a lot of people are, would be familiar with cataracts, or at least in general terms, maybe what cataracts are. But could you explain in more detail for us, like what does cataract surgery entail? And also some of the other things that you do with the front of the eye. In particular, I'm talking about implantable Collamer lenses and refractive lenses exchange.
Yeah, sure. So as we age, the lens basically sits behind the iris, which is the colored part of the eye. As we age, that usually becomes a bit foggy. So it kind of, you can see here, this is the lens that's fogged up, so it gets a bit foggy. When we're younger, it's quite clear, and there's lots of different types of cataracts, but basically cataract is an aging process where the lens or the window to the back of the eye fogs up, and you can have that for a number of reasons. Aging is the most common, that's what we think about, but you can get it from trauma or diabetes or medication related changes. But essentially, cataract surgery is the process of removing that lens and replacing it with a clear artificial lens through cataract surgery, which is done in a hospital environment, and the surgery itself is relatively quick. It's usually about 10 to 15 minutes per eye, and there's lots of different options for artificial lenses or prosthesis to replace that natural lens, which we can go through a bit in more detail. So that's your cataract surgery component. And then when patients want to replace that same lens, but before it's actually fogged or clouded up, that's called a refractive lens exchange. So it's basically the same process as cataract surgery, same type of surgery, but without actual changes in the lens structure or the lens clarity. So that's more an elective procedure to get rid of glasses or contact lenses, so to get spectacle independence. But the process is still similar. The risk profile is relatively similar. And then the last option for kind of lens-based surgery is implantable Collamer lens. So that's where a special customized contact lens, these are generally made in Switzerland. So they're little contact lenses that are customized based on your specific measurements in the eye and your prescription. So these are custom made to order in Switzerland, and they come over, and I place these essentially inside the eye. So this is our eye model here. You can see here, this is the cornea, so the front part of the eye, the iris, which is the colored part of the eye. And these implantable Collamer lenses actually sit here in front of the patient's lens. So I'm just showing you here. So this is the natural lens, and this is the implantable Collamer contact. So they sit in that space between the two. two. And they're really good for, again, to get glasses independence or contact lens freedom. Very, very good for people with very high scripts as well. So if you're like a -8 or 9 or 10 or even -15, you can get these custom made contact lenses to try and combat really thick, unpleasant glasses. So they're the three options: cataract surgery, refractive lens exchange, or some people call it clear lens extraction, which is probably a better name for it actually, and implantable Collamer lenses. So these are the three kind of options in lens-based surgery.
Right. Okay. So just to be clear here, so with cataract surgery and refractive lens exchanges, you're actually replacing the lens.
Correct.
Whereas with implantable Collamer lenses, it's
The lens
additive.
stays inside. So
yes,
cataract surgery and clear lens extraction or refractive lens exchange, we take away the lens and we replace with an artificial lens. With implantable Collamer lens surgery, we don't touch the natural lens. We just put a contact lens that's custom made in front of the natural lens.
Okay. So just to clear up some acronyms here, because eye care is full of acronyms. So ICL, that's another term
implantable Collamer lens, which you can think of as just a custom made contact lens for inside the eye.
Right. And I've heard IOL, is that intraocular?
IOL is, so that's an intraocular lens. So IOL is the lens that we replace the natural lens. That's the artificial lens that we replace the natural lens. So this is obviously a large version, but this is an IOL. So this is one of many different types of intraocular lenses. So these are the prosthesis or the artificial lenses that replace a patient's natural lenses. And these are used in both cataract surgery and clear lens extraction or refractive lens exchange. There's a lot of nomenclature, but it's actually quite simple when you break it down. It's just that in the eye world, we like to use complicated phrases for no particular reason, but actually it's not too complex.
All right.
And then there's heaps of different types of IOLs on the market. So there's an overwhelming number, and each surgeon will have their own preferences. I use a lot of different lenses, and the reason that is because every patient is very specific. So we look at so many different factors when we're doing cataract surgery or refractive lens exchange. You look at the pupil size, you look at the higher order aberrations, you're looking at the script, you're looking at how likely is that people are going to neuroadapt to the lens. So we look at so many different factors, and we take into account the occupation, what their visual requirements are, what are their goals of doing the surgery. Is near vision more important for them? Is distance vision? Is computer work? We have to really break it down. It's actually that side of things is quite complex, and it takes quite a long time of the consult. And then based on that, I work out what I use, actually a whole range of different companies and different lenses, and I customize or tailor them to each patient as it is appropriate. So I don't think that anyone should use the same lens on everyone. I think every patient should have a customized approach that will give you the best results.
Okay. All right. Well, so last time you and I spoke, we talked about LASIK surgery and smile surgery and presbyond also. All of those are things that happen with the cornea. Mm-hmm. So but if somebody comes to you, what kind of circumstances would prompt you to think, okay, well, maybe we should be talking about the lens rather than the cornea? Like what type of conditions, or what maybe is it their age, lifestyle? What sort of things would prompt you to talk about lens surgery rather than that front of the eye stuff?
Yeah. So look, when lots of the time patients will come with one of two things. They'll come to me because they've got some kind of refractive error or prescription. So they'll either be long-sighted or short-sighted, plus or minus presbyopia. They'll become presbyopic. So we spoke about this in one of the previous videos, but they lose the ability to see up close, which is an aging process that happens to most of us from 45 and over. So there's two factors going on. There's usually a script and there's usually presbyopia. Sometimes it's just presbyopia on its own. So these patients are then put into our clinic and they go through the whole process. So they get their corneas examined. We see if they're candidates for laser. And as we've discussed in previous videos, there's lots of factors that might preclude them from being laser candidates. So, thin corneas, abnormal topography, dry eye. We've spoken about this in detail. So I think they all go into this kind of box. Can they do laser or lens? Now, some people will be able to do both. Some people will be better candidates for laser and some people will be better candidates for lens. The better candidates for lens, if anyone has cataract, so clouding of that lens or any lens related changes, straight away they should have lens surgery. That's easy, because if they've already got changes, we're not going to be doing laser on the cornea when their lens has already got age-related changes, because their script is going to keep changing and they won't get a stable result with the laser, right? So for those patients, it's easy. If you've got early cataract, you get cataract surgery. It's a no-brainer. It's harder for the patients who are candidates for both. And usually most people, if they're candidates for both, they'll opt for the laser because it's less invasive, okay? So if they're younger and they don't have any cataract, so it's just a clear lens, but they can get the laser, most people will get the laser. Then there's a small cohort of people that aren't candidates for laser that will have a clear lens extraction. Does that make sense?
Yeah, sure. Yeah. And so what about ICL then in that case?
That's a different thing. So ICL is purely fixing, it's not presbyopia. This is more for younger patients. So what I was just talking about for cataract and refractive lens exchange, we're really talking about 50, 55 and over, okay? For young patients in their 20s or 30s or 40s who have very high scripts, or even if they don't have high scripts, I've done low scripts as well. But if they're not candidates for laser, again, because of all the factors, lots of the time it's thin corneas and things like that, then they can have these implantable Collamer lenses or these implantable contact lenses custom made. And this doesn't touch their natural lens. This is for young patients who just want to get out of glasses or contacts. And the beauty of it is that it's reversible because we're not altering the corneal architecture. We're not removing tissue. It's reversible, so you can always have that contact lens taken out. Obviously, it's done in an operating theatre, so it's not quite as simple as just whipping it out in clinic. Like, you still have to go back and have an eye operation, but it is reversible. And, you know, I put these in 20 and 30-year-olds all the time. And then later on in life, when they're 60 or 70 and they develop a cataract, then it stays in their eye their whole life. We take it out at the time of cataract surgery, and then we go on and remove their natural lens and put in the artificial lens for cataract surgery. So it's something that can be with them their whole life until they develop a cataract.
So would implantable Collamer lenses also be a good option for somebody who has severe dry eye syndrome then?
Yeah. I mean, it will still cause a little bit of dryness because all eye surgery does, but it might be a better option. Although we do have Smile as well, which is good for dry eyes. So look, I think this is a case-by-case thing. This is what I keep harping on about, but it's very true. It comes down to many factors, but like a lot of the time with ICLs, it's in people that have high scripts. I commonly do these in high myopes who actually we don't have enough tissue to do the laser, or if doing a laser in someone with that script might cause instability of the cornea or regression of the script down the track. So that's like the most common scenario. But as I said, if you're not a candidate for laser, you can have these in lots of different scenarios, even with like a -2 or a -1 prescription.
Interesting. All right. Well, if you're watching this on YouTube right now and getting value so far, can I ask you to please hit the like button? It greatly helps us with the YouTube algorithm and improves the odds that other people will get benefit from this also. So Erica, I'd like to ask you a little bit more about how lenses can help people become free from reading glasses. We've talked at length in our previous video about Presbeyond, which is a laser procedure, and I'd encourage anyone to go back and watch that again. But can you explain a little bit about how lenses work in terms of like blended vision and focusing on, you know, multiple distances? How does that all work?
So basically there's, as I've mentioned, there's lots of different lenses on the market. When you're starting to look at getting rid of reading glasses, you're looking at multifocal intraocular lenses. So these are lenses that, as the name suggests, correct for multiple distances. So correct for distance, intermediate or computer vision, and near iPhone vision. Traditionally, these are split into two classes. So there's extended depth of focus lenses. So these lenses are very good for correcting for distance and computer, and they will give you some near vision if you kind of perform a mini monovision setup. So, you know, if you make your dominant eye, it's actually very similar to Presbeyond like we spoke about. So you give your dominant eye more of a distance focus and your non-dominant eye more of a near focus. So these still give my patients extremely good range of vision. They usually give functional near vision similar to Presbeyond. So iPhone, they do not give very minute detail. So if you want to look at threading a needle through an eyelet, unlikely, but they give very good like restaurant menus, back of medicine bottles, things like that. Usually I find that they give around kind of the J3 to J5 near vision. So it's pretty good. And the benefit of these is that they're very robust lenses. The optics aren't too complex, which is a good thing. So later on in life, if you go on to develop glaucoma or macular degeneration, they're usually highly tolerated. So I like them because they're kind of future-proofed. You know, it's one thing putting a lens in a 59-year-old who doesn't have any eye problems, but then in 15 years, if they go on to have eye problems, you still want a lens that will be able to stand the test of time. And they also have minimal side effects. So some of the side effects of multifocal lenses lenses are glare and halos. So glare is usually when you look at a street lamp, you might get like a halo or ring, and you might get kind of increased starbursts or those kind of visual aberrations. So they don't have none, but they usually have less. And I'm finding that each generation of extended depth of focus lens, I'm using the Pure C extended depth of focus from Johnson & Johnson predominantly at the moment, and I find that there's very minimal side effects. Usually patients get them for the first few weeks and then they go away as they neuroadapt.
Right.
So that's your extended depth of focus, and I usually put that in the middle. And then you've got trifocal lenses. So these are also multifocal lenses. These truly correct for distance, intermediate and near without having to do any monovision setup or mini monovision setup. So both eyes will have distance, intermediate and near. We're not looking at dominance and all of that like we are with Presbeyond and the extended depth of focus. These give much, I think generally they give a finer near vision, so you can see smaller things. But I do find sometimes there is a slight compromise in the distance vision with some of the lenses. So patients still get extremely good distance vision, but sometimes they say it's not as clear as it was in their glasses. And this is because the optics is quite complex with these lenses, as you can imagine. So, lots of them have rings. There's lots of different types. I use the Galaxy as well, which is from Raynard. It's got this spiral optical arrangement. There's lots of different ones. So upside is that you might get a slightly larger range of vision and maybe slightly better near vision. Downsides are you're more likely to get some glare and halos. Even the later models like the Galaxy, you still get a little bit of glare and halos. It's much better than previous models, but there's still some. And if you do develop other issues later in life, it may not be as future-proof. So you might never, but if you get really bad glaucoma when you're 85, it might not be as forgiving as an extended depth of focus lens. So you can see that it's quite complex. There's pros and cons to both. And again, it comes down to like what my patients want, what they're after. So if someone tells me they want to see extremely fine near vision, then you might think trifocal. But then if someone tells me they'd be really bothered by glare and halos at night, you'd probably err away from the trifocals. So, things that are important, are they a night driver? Are they a truck driver that drives all night? Are they seamstress? Like you have to get a lot of information about their daily tasks and what their visual goals are. But basically, both lens categories that fall under multifocals are great. They have pros and cons, and they can be very effective when you select the right patient. And I think patient selection is critical, and you don't always get it right. And patients also have to have realistic expectations, which as the doctor, we need to obviously give them realistic expectations. So there's never any 100% guarantees with any of these lenses of being completely glasses free. A lot of the time we get that, but like anything, there's no 100% guarantee. So you have to make sure patients are aware of that. And there's obviously risks of the surgery itself. Whilst they're low, it's still eye surgery. So that all needs to be really reinforced with the patients. But overall, this is amazing surgery.
So this might be also a good point to ask about cost, because I think you've described various types of lenses, and I think some of those would maybe come under the category of premium lenses.
So extended depth of focus and trifocals, which are multifocal, are both premium. Like that's premium. That's all under the premium lens category. So if you have a cataract surgery done in the public system in New South Wales, you don't have access to any of these lenses as a general rule of thumb. So you only have access to what's called a monofocal lens. So that's a lens that just corrects for one distance, whether that's distance or near. For the majority of people, it's distance. So they get correction for distance, and then you wear glasses for reading and computer. So that's the most simple lens. That's not a premium lens. It's just a monofocal lens. And then the premium lenses, as I've described, the extended depth of focus like the Pure C, and the trifocal like the Galaxy. And then there's obviously different options that I use depending on different patients. I think one thing that's important to realize as well when you're talking about costs is with cataract surgery, if you have private health insurance, a lot of the lenses are covered through that. And then also Medicare covers some of the procedure. So if it's a cataract surgery, whilst you're still going to be out of pocket for some money, it's generally a lot less expensive than clear lens extraction or in ICL surgery, because both of those procedures are considered purely elective. So that's kind of in the category of Presbeyond and laser eye surgery. That's more elective, trying to get it purely out of glasses. So there's no Medicare coverage, and health funds don't cover that generally either. Whereas cataract surgery is kind of financially, you're in a different category because private healthcare and Medicare cover components of the surgery. So it's just important for patients to be aware of that as well.
I'm not sure if there's any like differences between different states, like, Queensland might
Yeah,
have a
no, I'm
different
just
system.
purely talking
Yeah.
about our
Yeah.
practices, our
Yeah.
two practices in Sydney.
New
Patients
South
should
Wales.
definitely speak to their own private healthcare providers and their own ophthalmologists if they're interstate. But yeah, this is just from my perspective in New South Wales.
Okay. All right. Well, you touched a little bit on patient expectations.
Mhm.
So, what would you like patients to be aware of before they, proceed with any kind of lens surgery? Like should patients expect to be completely glasses free, or what should they really expect as an outcome?
So it depends what we're talking about. So there's the implantable Collamer lenses and then there's the cataract and clear lens extraction. Look, put simply, when patients come to our practice, they go through quite a thorough consent process. So we go through all the risks of lens-based surgery, including things like retinal detachment and retinal tears, infection in the eye. All of these things are super rare, but patients need to be made aware of the possibility of them in very unlikely scenarios. So we go through the kind of a risk profile, and you can see all of that on our website. And then obviously I also go through that in detail with patients in the practice, and they have a very thorough consent form that they can read as well, and a booklet. So there's the risks of the surgery, and then there's just things that they need to be aware of about the premium and all the multifocal lenses. I've kind of already touched on these, but there's the neuroadaptation period. So similar to Presbyon, you'll have a bit of that time where your brain needs to get used to the optics of the lens because it's not your natural lens. Then also we've touched on side effects of the lens, so glare and halos at night. And then most of our patients, I would say, a really high proportion of our patients are glasses free because that's the whole point of the surgery, especially for implantable Collamer lenses and clear lens extraction. That's the whole point. So, whilst we say we can't 100% guarantee it, lots of patients are, but you have to be aware that there's still a small chance of needing reading glasses. Most of the time we can fix any distance refractive errors because we have laser here. So we can always do a laser touch up on top of a lens-based surgery if we need to. We rarely have to do that because our lens calculations these days are very, very accurate. We find that we're within, 0.25 to 0.5 diopters like all the time. Like it's very consistent. Don't really get many refractive surprises. And I think that's lots of surgeons now just because, we have the Iowa Master 700 from Zeiss, which is extremely accurate. At my practice, I perform integrated K. So I actually use keratometry readings from multiple machines and I average them. So I find that from a refractive surprise scenario, whilst it's possible, it's not common. And I think patients that have had previous laser surgery, again, there's traditionally they have slightly higher risk of refractive errors because they've had previous laser eye surgery and then you're doing a lens in an eye that's already been altered. But again, the calculators that are available now, we have the Barrett True K calculator, which is extremely accurate, and EVO has a calculator as well. So these calculators, I do a lot of lens surgery in patients that have had previous laser eye surgery, and I find the results are extremely accurate as a general rule of thumb. So I guess to summarize, there's three components. There's the risks of the surgery, which we discuss in detail. There's the side effects of the lens that we discuss in detail, and that's based on the lens that we go ahead and select for you for your surgery. And then there's the expectation to be glasses free, which most of the time we can deliver, but obviously there's a small chance that in certain scenarios we can't, and patients have to be aware of that because in life there's never any 100% guarantees of anything.
All right. Well, let's just to finish up, let's talk about some of the practicalities of preparing for the day of surgery and then what comes after that. So, is there anything that people should do to prepare for the day of surgery? Like, for example, stop wearing contact lenses, arrange transport, eye drops, and so on. And then what happens after the day of surgery? Like, what is the follow-up what does the follow-up process look like?
Yeah, so it's a little bit different to Presbyon. Presbyon we do in our practice here at Mosman in our laser suite. But for lens-based surgery, I operate in a private hospital. So I have a number of different locations around Sydney for that. So patients select the location based on usually their geographic location. We actually have a number of different sites, so it's pretty good. Patients have quite a wide selection. So most patients need a chaperone to take them to the surgery for the day. As I mentioned, the surgery lasts about 10 to 15 minutes. Similar to Presbyon, there's not really any pain during the surgery, but the difference is that you're usually you're sedated so we have an anaesthetist on site at the hospital who gives sedation via an intravenous line. So you're very drowsy during the surgery. So it's not different to laser surgery where you're quite alert because we need you to be alert to look at the light, to focus on the light. But for lens-based surgery, we don't need that. So chaperone because you're going to get sedation. You won't really know what's happening during the surgery because you're sedated, but the surgery lasts about 10 to 15 minutes. And then No, not really any pain afterwards. People again say that the eye's a little bit gritty, similar to laser eye surgery, but very quick recovery, similar to laser eye surgery. Next day, vision's very good. My patients can see after lens-based surgery straight away because I don't use any needles in the eye. So I do all my surgery under drops or topical, so drop-based surgery, which means that the freezing agent is just on the surface of the eye. So that means that when they leave the operating theatre, they have plastic shields over both eyes, but they can still, whilst it's blurry, they can still see. And the reason that's important is because for lots of these surgeries, I do both eyes on the same day. So for all my clear lens extraction surgery and for all my ICL surgery, I do both eyes on the same day. So then patients are able to, again, it's not clear as straight after surgery, but they can see so they're not falling over because they've had both eyes done. And then they can go home with their chaperone. They usually see us at day 1 week and 1 month in the clinic. And yeah, it's quite an easy process. We go through, our staff are here fantastic, so they go through it really in great detail with the patients.
So you said you usually do both eyes for ICL or intraocular lens replacement.
So for for refractive lens exchange and for ICL surgery, because it's an elective procedure and it's not covered by Medicare or private health cover, most patients opt to have both eyes on the same day. And the reason for that is generally a financial reason, because if they don't do that, they'd have to pay for the private hospital twice and the anaesthetist twice. So whilst it's actually a combination of many things. There's a financial reason. There's a reason that lots of these patients are extremely busy people, like they're, have their own business or they're professionals. I do a lot of, people that just are very time limited. So then again, you're doing both eyes on the same day. It also helps with anxiety. Some patients don't want to have to go back twice. They just want to get it over and done within one hit. So you can see there's a lot of reasons that people might elect to do both eyes on the same day, but because it's an elective procedure, it makes the most sense. Also, if you're doing one eye that has a very high script and then you wait 2 weeks for the other eye, you can get quite a lot of imbalance from that. So again, for neuroadaptation and for comfort, it makes sense to do both eyes on the same day. So you're not walking around with one corrected eye and one eye that's a -9. So there's so many different reasons. At the clinic here, we're very used to doing both eyes on the same day, and that very much follows an international model. So I did my fellowship in Toronto, Canada. I did a 2-year refractive and corneal fellowship in Toronto, and it's very much the norm to do same day surgery over there. It's huge in Europe as well. So this is not a new thing. It's very common on an international kind of scale, and we're just bringing that to Australia, and lots of surgeons here do it as well now. It's becoming more mainstream, but it's still not necessarily the norm. Now, having said that, if patients want to split their eyes, I have no problems with that. There's also some advantages to separating eyes, and that's a discussion that I have with the patients. The cataract surgery, it's very different because it's usually covered to some extent by private health cover and Medicare. Lots of patients opt to separate their eyes, and that's totally fine. Again, I leave that up to the patient, but I'm comfortable doing either because I think there's benefits to both.
So I'm curious about one thing. For in the case of somebody who does get their eyes done at different times, and let's say cataracts, for example, somebody gets one eye treated, the other eye is untreated. How do they manage, life with like eyes that are not the same that way? I mean, they still need glasses.
Lots of them are contact lens wearers, so it's quite easy because you can just put the contact in the eye that hasn't been treated. So that's easy. If they're not contact lens wearers, we usually pop the lens out of the side that's had the surgery so they can still wear their glasses. But in lots of cases, I try and do them within a short period, so only a couple of days or a week, something that's not too distressing for patients. But yeah, anisometropia, which is the difference between the two eyes, is definitely something that we talk to patients about before the operation. We let them know about that. Most patients, it's a real mix. I do so many same day cases though, where I do both eyes on the same day. I don't have too much of that, but it does happen sometimes.
And in the days and weeks after surgery, do patients need to wear an eye patch when they go to sleep? Are there any things that they need to do?
Just a plastic shield overnight for the first week. During the day, just some sunglasses when you're outside, just so you don't get dust and things like that in the eye. Otherwise, really, it's just no heavy lifting for a week and no swimming for 2 weeks in the ocean because we don't want to get any nasty bugs. But aside from that, it's pretty quick. Very similar to laser surgery. The recovery is very quick.
And what's the idea of the night shield, by the way?
It's just like laser surgery. It's just so you don't rub your eyes at night. So when we're sleeping, we don't know what we're doing. And especially when you're in REM sleep and you're really in that deep sleep, you don't know if you'll accidentally rub your eye. So it's just so you don't open up any wounds or anything like that. One thing I forgot to mention before, Paul, is with the premium lenses as well, we touched on, the multifocal lenses, but I didn't actually mention toric lenses. So these are lenses that correct for astigmatism, because I get a lot of patients asking me, can I fix their astigmatism? So the answer is yes. We can fix astigmatism extremely well with modern lens technology. And so the premium lenses or these multifocal lenses have toric range. So you can have those special lenses, but also correcting for your astigmatism based on calculations. So we can have what's called toric premium lenses as well.
All right. Well, thanks a lot, Erica. I think this has been incredibly insightful. Do you have any last words of advice for people needing or considering lens surgery?
Not really, just for people to be really open-minded when they come to our clinic. We offer, we're one of the few clinics in Sydney that can offer everything. So we have, Presbeyond, which is our laser option. We have Smile Pro, LASIK and PRK. We have ICL surgery. We have clear lens extraction or refractive lens exchange, and then we have cataract surgery. So we've literally got all the options. So when you come to our clinic, you can be rest assured that we're picking the best option for your eyes. We're not just picking an option that suits us. We have the whole array, like the whole range, and we'll pick the one that's best for you for many reasons. It's occupation related, it's anatomy related, it's lifestyle related, it's based on your visual requirements. So we really think deeply about this. That's why our assessments are so long. They take up to an hour and a half, and patients sometimes say, why is it so long? And that's why, because we're deeply thinking about what's going to give you the best option. Lens-based eye surgery is great. It has excellent outcomes. Like all eye surgery, it still has risks, and these need to be discussed with the patient. But overall, it's just another fantastic area of eye surgery. I'm very biased, much better than retina surgery. So that's all I would say. I would just say that, at our clinic at Eagle Eye Surgeons, we can offer all the different types. And this video is just the lens-based surgery. We've touched on the laser-based surgery, and together we can give you the best option for you.
Great. Excellent. So where can people reach you if they're curious about whether lens surgery could help them?
So we have obviously our website. You can give us a call at our clinic. We have 2 sites in Mosman and Nepean. We also have ads usually running on the internet. So if you click on those ads, they'll go through to Health Engine, and you can book appointments through Health Engine. There's lots of different ways you can reach out. We have an Instagram profile. I get lots of messages through that. So whatever works for you. Usually you can just call our clinic. Our staff are very friendly, but whatever works for you. And thanks for watching the video.
All right. And once again, if you've found this helpful, we'd love it if you hit the like button to help others find it also. And subscribe to the Eagle Eye Surgeons YouTube channel for more useful content, and follow their Facebook page and Instagram for updates on the latest treatments, promotions, and events. So thanks a lot, Erica.
Thanks, Paul.
All right. Thanks everyone for watching. Take care. Bye-bye.